Welcome back to the deep dive. Today, we are opening up a topic that strikes fear into the heart of many plastic surgery residents:
Okay.
craniofacial atrophy and hypoplasia.
It's definitely one of those areas where the textbooks are dense, the classifications just seem endless, and the margin for error in the exams is, well, it's tiny.
Exactly. And that is our mission today. We're taking a stack of papers, the classic textbook chapters, and we're distilling them down into a high-yield, rapid-fire revision tool.
Right.
We are not going to get bogged down in basic anatomy. We are focusing on the boards, the classifications, the surgical algorithms, the gotcha
We're
questions.
talking hemifacial microsomia, Treacher Collins, Pierre Robin sequence, and, the acquired deformities like Perry Romberg. It's a full menu.
Before we jump in, just a quick bit of housekeeping. If you're a regular listener and these deep dives are helping you, please take 5 seconds and rate the show. It really helps other residents find us.
And leave a comment on what topic you want us to tackle next.
Also, I need to be really clear about something. Today is about the facts, the theory, the bookwork. But if you're prepping for the Viva, knowing facts is not enough.
You need to know how to apply them.
You need to apply them to a scared patient in a clinic room. You need to see the x-rays and, make the calls.
Right. And that's exactly what we do in the premium subscription.
It is. Our separate clinical cases series is where we break down actual patient scenarios, the landmark papers you need to quote. So if you want to pass the clinicals, you need premium.
Simple as that.
But for today, let's get your theory bulletproof. Let's start with the big one. The most common facial birth defect after clefts: hemifacial microsomia.
Or, if you want to be pedantic, and examiners often do, you might hear it called first and second branchial arch syndrome.
Right, or automandibular dysostosis.
Which, it kind of gives away the pathology, doesn't
It
it?
tells you exactly where the problem is.
It does. It's a failure of development in the first and second branchial arches. The key thing here for the written boards is the etiology. Unlike some of the other syndromes, HFM is rarely purely genetic.
So what's the leading theory? If a resident gets asked, why did this happen? What's the model answer?
The vascular theory. That is the gold standard answer. The idea is that around the 4th week of gestation, there's a hemorrhage from the stapedial artery,
A bleed.
a bleed. It creates a hematoma, which then causes ischemia in the developing tissues of those first and second arches. The size of the bleed dictates the severity.
Which explains the variability, right? From just a little ear tag to half a jaw missing.
Exactly. It's a huge spectrum. And incidence-wise, you're looking at about 1 in 4,000 live births.
Okay, here is the first major fork in the road for the exams. You have a child with a small jaw, ear issues. How do you distinguish hemifacial microsomia from Treacher Collins syndrome?
This is fundamental. Hemifacial microsomia is typically unilateral and asymmetrical.
One side.
One side. And even in the rare bilateral cases, one side is always much worse. And it's sporadic. The parents usually have normal faces.
In Treacher Collins.
Is the complete opposite. It is bilateral, it is symmetrical, and it has a strong autosomal dominant inheritance pattern.
So, symmetry, think Treacher Collins. Asymmetry, think HFM.
That's the rule.
Perfect. Let's drill down into the clinical features of HFM. What does it actually look like on a patient?
You need to scan the face systematically. Start with the ear. You'll see microtia, maybe anotia, conductive hearing loss. Then the jaw.
The mandibular hypoplasia, that's the hallmark.
It is. The zygoma might be flat, but don't forget the soft tissue.
That's a common miss. People just focus on the bone.
Right. And these patients have hypoplasia of the muscles of mastication, the facial muscles, often the parotid gland, and crucially, check the nerves.
Facial nerve.
Facial nerve weakness is common, often the marginal mandibular or buccal branches.
And what's the specific variant that involves the spine and eyes, that triad?
That's Goldenhar syndrome. It's essentially HFM plus epibulbar dermoids, those growths on the eye and vertebral anomalies, fused neck vertebrae, things like that.
So if you see a neck issue or an eye growth, it's Goldenhar.
You got it.
Okay, classifications. High yield territory. We love an acronym. What is OMINS?
OMINS is the most comprehensive system. It grades the whole picture. O for orbital distortion. M for mandibular hypoplasia, E for ear anomalies, N for nerve involvement, the facial nerve, and S for soft tissue deficiency.
But it doesn't really dictate surgery, does it? It's more for documentation.
Exactly. For surgery, especially the mandible, we rely on Przansky. You need to have this one memorized.
Okay, walk us through the types and focus on why the type changes the operation.
Okay, Przansky type I, that's the mildest. The mandible is small, but all the parts are there. The ramus and condyle are just miniature.
Right. Now, type 2 gets split into A and B. What's the defining feature there?
The functional joint. That is the absolute key. In type I, the condyle and ramus are small and abnormally shaped, but
It still works.
it still works. The relationship between the condyle and the glenoid fossa is maintained. The joint functions. In type I, that relationship is gone.
So it's a non-functioning TMJ.
A non-functioning TMJ. The condyle is just floating. And type 3.
Total disaster.
Yep, the ramus is absent. No conda, no TMJ.
Before we fix it, quickly, the other two classifications, SAT and Merman.
SAT is David's classification, skeletal, auricular, soft tissue. Merman is just for the ear. Grade Hund is a malformed ear. Grade 3 is a remnant, and grade 3 is anotia.
No ear at all.
No ear.
All right, let's solve the problem. You have a patient with HFM. The parents are anxious. Walk us through the timeline, starting with the baby.
Okay, under 2 years old, we are very conservative. We're just finishing the face. So if they have microsomia, we do a chemisauroplasty. We remove any skin tags.
And hearing aids.
And prioritize hearing aids, absolutely.
Right.
But we don't touch the bone yet.
Okay, school age. 2 to 6 years old. The deformity is becoming noticeable. Now what?
This is the window for the mandible. The workhorse is mandibular distraction osteogenesis. We cut the bone, we stretch it, and we grow new bone and soft tissue.
But wait, what if it's a Przansky type 3? You can't distract fresh air.
Precisely. And that is a classic Viva trap. If there is no bone stock, you have to build it first. That means a costochondral rib graft to reconstruct that missing ramus and condyle.
Right. Moving on to the teenager, say 6 to 14.
Now we're focusing on the ear. You need the rib cartilage to be big enough to carve a framework, usually around age 9 or 10.
And orthodontics?
Serious orthodontics. Yeah. And we can start augmenting the cheek with fat grafting or a free flap if needed.
And finally, skeletal maturity. 16, 17 years old. What's the final polish?
This is definitive orthognathic surgery, or OGS. We cut the jaws Lafort, BSSO, get the occlusion perfect, maybe add some onlay bone grafts or medpore implants for symmetry.
Yeah.
And then we're done.
Excellent. Let's pivot. Treacher Collins syndrome, you said. Bilateral, symmetrical, autosomal dominant. What gene?
Usually TCOF1. It affects the treacle protein.
I always found TCS easier to spot. The features are so consistent. Tessia clefts 6, 7, and 8. Run through the checklist. Start with the eyes.
The eyes have an antimongoloid slant. They slope down. They have colobomas, which are little gaps in the lateral lower eyelid. And interestingly, they often lack eyelashes on the medial part of the lower lid.
And the cheekbones are just gone.
Essentially, yes. The zygoma is hypoplastic or absent, which gives that droopy look.
And the mandible is small, retrusive, giving them that convex profile. But the ears are involved, too.
Yes. Similar to HFM, you get microsomia or cryptotia.
But with Treacher Collins, the biggest fear isn't cosmetic. It is the airway. Why is that?
Because everything is small and tight. The maxilla is hypoplastic, the mandible is tiny micrognathia, and the pharyngeal airway space is critically constricted.
So a baby is born with PCS, struggling to breathe. What's the escalation ladder?
Start simple. Prone positioning. Gravity pulls the tongue forward. If that fails, maybe a nasopharyngeal airway, an NPA.
But in severe cases?
In severe Treacher Collins, don't be a hero. A tracheostomy is frequently required, and it is life-saving.
And surgically, the timing for zygoma reconstruction is different from HFM, right?
Yes. We usually wait until 7 years or older to use calvarial bone grafts for the orbits and zygomas. The skull needs to be thick enough. And you wait on the nose until after the big jaw surgeries.
Okay, before Pierre Robin, let's clear up the lookalikes. Nager and Binder syndrome. How do I tell Nager's from Treacher Collins?
Nager's has an identical face to Treacher Collins. The tell is the hands. Nager's is Treacher Collins plus limb anomalies.
So look for thumb hypoplasia.
Thumb hypoplasia, radial defects. Also, it's autosomal recessive, not dominant.
And Binder's?
Binder's is maxillonasal dysplasia. Think boxer's nose. Short, flat bridge, absent anterior nasal spine. They have a very flat midface and a class 3 malocclusion.
Got it. Okay, let's tackle Pierre Robin sequence. First, why do I get told off if I call it a syndrome?
Because it's not a syndrome. A syndrome is a collection of signs from a single cause. PRS is a sequence, a domino effect.
So what's the first domino to fall?
Mandibular hypoplasia. The jaw is too small in utero.
And because the jaw is small, the tongue
has nowhere to go but back, so it gets pushed backward. That's glossoptosis. And because the tongue is sitting high and back, it physically blocks the palatal shells from fusing.
Causing the third domino, a cleft palate.
Exactly. Micrognathia leads to glossoptosis, which leads to a cleft palate, usually a U-shaped cleft. That's the triad.
Now, management is debated, but for the exam, we need a framework. The Birmingham Children's Hospital classification, break it down.
It's all about how invasive you need to be. Grade 1 is mild. You nurse them side-lying, they're fine, they can feed.
Grade 2.
They still have airway issues managed by positioning, but they're struggling to feed. So they need positioning plus an NG tube for feeding.
And grade 3 is the severe group.
Right. Positioning isn't enough. They are desaturating. These babies need a nasopharyngeal airway, the NPA, to stent the airway open, plus NG feeding.
And you can't just send a grade 3 baby home like that. What are the discharge criteria?
Safety is everything. They have to be gaining weight. The parents need full training in BLS, how to manage the NPA, how to replace the NG tube, and they usually go home with an overnight pulse oximeter.
Most of these kids have catch-up growth, don't they?
They do. The jaw grows, the airway opens up. But if it doesn't, you have surgical options.
Like what?
Glossopexy, or a tongue lip adhesion, mandibular distraction, or the ultimate safety net, a tracheostomy.
And one final parole for PRS. Baby with a cleft in a small jaw, what syndrome must you screen for?
Stickler syndrome. It's a connective tissue disorder. You must send them to ophthalmology. They are at high risk for retinal detachment and blindness. If you miss Sticklers, you might miss saving their vision.
Okay, home stretch. Acquired deformities. Let's start with progressive hemifacial atrophy, or Perry-Romberg.
This is a fascinating and devastating condition. It's a neurocutaneous syndrome where half the face just slowly wastes away. Skin, fat, muscle, bone, everything.
And the onset?
Usually school-age kids. The classic sign is the coup de sabre, a linear, depressed scar on the forehead. Looks like a sword cut.
Okay, the million-dollar question for the boards on Perry-Romberg is timing. A 12-year-old comes in, half her face is wasting away. Do you operate?
Absolutely not. And that's a hard conversation, but you have to hold the line. Perry-Romberg is an active disease. If you put a fat graft or a flap into an active disease bed,
The disease just eats it.
it just eats the new tissue, so you have to wait for burnout.
What does that mean?
You need clinical stability. No changes in the face for at least 12 months, confirmed with serial photos. Only then do you reconstruct.
And once they're stable, what are the options?
It's all about volume. For mild cases, fat grafting is great. For severe cases, you need free tissue transfer. A periscapular flap is a good choice.
Why do we prefer hypoplastic flaps over muscle flaps for this?
Because muscle atrophies. If you use a muscle flap, it can shrink over time and you lose the result. Fat and fascia hold their volume better in these patients.
Lastly, radiation-induced atrophy. We see this in childhood cancer survivors. What's the mechanism?
It's a growth arrest. High-dose radiation kills the growth centers, the sphenoid bone kind of locks in, and the sinuses fail to expand. So the child grows, but the radiated part of the face stays infant-sized.
And the treatment must be massive.
It's heroic surgery.
Yeah.
You need osteotomies to break the locked bones, distraction to stretch them, and usually a free flap to bring in a healthy, non-radiated blood supply.
All right, that was a marathon. Let's synthesize. If you are walking into the exam tomorrow, what are the 3 things you cannot mess up?
Okay, number 1, differentiate HFM from Treacher Collins. HFM is unilateral and sporadic. TCS is bilateral and dominant.
Number 2.
Know the PRS algorithm. Positioning, then NPA, then surgery. Don't jump straight to a track.
And number 3.
Never, ever operate on active Perry-Romberg. You must wait for burnout.
And here's a final thought, something that might separate a pass from high honors. We talked about the Birmingham model for Pierre-Robin NPA, and wait, it works.
It does. It's very successful.
But there is a growing school of thought that says waiting is wrong.
Right. Some centers argue that if you do mandibular distraction early, in the neonatal period, you fix the root cause immediately. You avoid months of tubes and failure to thrive.
But the risk?
But distraction in a newborn carries real risks, including a small but quantifiable mortality rate.
And being able to discuss that trade-off, the safety of the MPA versus the definitive nature of early surgery, is exactly the kind of higher-order thinking examiners love.
It shows you're not just memorizing. You're thinking like a surgeon.
We're going to wrap it there. If you want to see the papers debating that PRS controversy or see photos of a Przansky III reconstruction, you need to go to the show notes and subscribe to Premium.
The Clinical Cases deep dive for this topic drops on Thursday. We'll see you there.
Good luck with your revision. Catch you next time.